Good morning, everyone. We're going to give it a few minutes for people to join us, and then we'll start. Again, welcome everyone. We're going to give it a few minutes for people to join in, and we will start in just a minute or two. Thank you for your patience. Okay, I think we're going to go ahead and get started. We have a pretty full program today. Just a few housekeeping items. This video is being recorded, so please be prepared to know that, and we will have it available via our YouTube channel at the end of next week. Please use the chat feature for technical questions only. For all other questions, please use the Q&A feature at the bottom of your screen. On that note, again, welcome everyone, and I'm going to hand it over to Ann Jones. Ann, you need to turn yourself off mute. There you go.
Thanks. Hi, good morning, everybody. Thanks for joining us this morning. Our agenda for today is first a welcome and remarks from the chair of our Board of Healthcare for All Minnesota, Dr. Mark Bracke. We'll get a financial report or a treasurer's report from Don Kilkenin, our secretary treasurer, and a development committee report from the chair of the development committee, Dr. Jim Hart. Then we're going to hear from our speaker, Rose Roach, on threats to original Medicare. We should have time for a few questions. We will see how that part goes, and then also we'll get a report from Rose on new caucus at the state legislature that we're really excited about. Also, then Carolyn Henke, our social media expert, will talk a little bit about social media initiatives and sites for Healthcare for All Minnesota, and I'll have some announcements at the end and a wrap up by our host and our administrative coordinator, Judy Barton. So again, thank you for joining us, and I'm going to ask Mark Bracke to share some remarks with us.
Good morning. Thank you all for joining us this morning. We are always pleased to be joined by our fellow advocates for healthcare justice reform. I just want to make a couple of comments initially about 2021. We made good progress in 2021 on a number of fronts. we started out early in the year. We hired an excellent administrator who unfortunately ended up being stolen away from us by the American Cancer Society. But then we got fortunate again, and we've acquired another excellent administrator, Judy Barton, who is helping to manage today's meeting and does a great deal of valuable work for us every week. We also have an excellent social media content creator, Carolyn Henke, who has been working with us since May or June of this year. And she's going to talk to you a little bit later on today. The last general item I want to mention is that there's been some really excellent fundraising work done this year. There have been a lot of people involved with that, but a couple of people who have been quite key are Carol Engelhardt and Cheryl Quick, and we all owe them a vote of thanks. I am going to turn my video off because I'm out in rural Wisconsin and my bandwidth is not very strong. And I think that my connection will be a little more stable if I am not on video. So the topic I wanted to talk about this morning relates to messaging. We're in a situation now where the majority of Americans think that U.S. healthcare is messed up and needs to be reformed, but they don't really know enough to be comfortable with exactly which way things should go. We have a particular problem with rural voters. So I was reflecting on this recently, and during the years I practiced medicine, I learned something early on, and that is that even though there are things that people need, and indeed they often know that they need it, they have trouble making a change from what they're currently doing to what they should be doing. A couple examples. One is colonoscopy. I never had a patient come into the office and say, "Hey, doc, I need to get my colonoscopy. Can you get it scheduled as soon as possible?" And one of the other areas that was always problematic was people with diabetes who needed to go on insulin. There was a great fear among the patients of taking injections and injecting themselves with insulin. And what I found out was that there were several things that had to happen for people to be willing to do what was best for them. First of all, they needed to know that I really cared about them as people. Then they needed to understand the details of their problem and why it needed to be treated. And they needed to understand the treatment itself. And they also often needed a significant amount of time to process this new information. And I think that voters are very much like patients. The voters have some major needs. The voters have significant fears, and it's our challenge to figure out how to message them effectively, taking those things into account. I think that each of us in this movement got to the movement through unique paths. Some people got here as a result of their moral and religious beliefs. Some arrived as a result of a general desire for a just world. Some arrived because of a sense of outrage at the economic injustice of U.S. healthcare. And we need to look at the voters as unique individuals so that when we're in one-to-one conversations with them, we need to find out what it is that they're concerned about, what it is that motivates them, and then be able to address them as unique individuals rather than trying to give everybody exactly the same message. So I guess the theme for me this morning is know your audience, tailor your conversation to their needs, start out by asking questions, listen carefully to their answers, and try to address their unique needs and concerns. Well, with that, I want to thank you once again for all of the hard work and dedication that you bring to this essential drive for healthcare justice. And I'm going to turn the program over to the next speaker, who I believe is going to be Don Pilkinen.
Thank you, Mark. Don, can you go ahead and give us the treasurer's report for this morning?
Yes, I will, Anne. And thanks, Mark, for your opening comments. I hope everybody can hear me. Yeah, regarding messaging, money talks, and that's kind of what I'll be addressing right now. At year's end, it's important to report that expanding our education and outreach statewide for single-payer universal health care means paying the expenses for this ever-increasing workload, which breaks down into 4 categories of expenses. They are our social media development, which is expanding capacity for greater attraction, monthly fees that need to be paid for the Every Action platform for transmitting notices and alerts to our growing base of supporters, monthly fees for more Zoom meetings and webinars, which are engaging more attendees, and fourth, printing and copying expenses for handouts, signs, t-shirts, banners, and buttons with the HCAM brand that identify more of us at more events. And it looks like the work will expand in 2022 due to our coalition builders meetings with representatives of potential allied organizations, the 3 education webinars for constituents and legislators that Kip Sullivan and Mark Peterson have developed, and tabling and flyering at Pride Fest and Farm Fest next summer, and other events which have insurance and other expenses to be paid. So far, we've been able to handle the growing expenses thanks to money raised from your donations and successful fundraising events organized by Carol Engelhardt and conducted by many hardworking volunteers that has surpassed 2020, which Jim Hart will report on. And now that HCAM is a 501c3 organization, our website makes tax-deductible donations easier with the donation button on the upper right corner of the website's homepage that connects you to the contribution page. If you prefer donating by check, you can get a tax deduction by writing your check to the HCAM Education Foundation. We highly appreciate your financial support in 2021 and for the work that lies ahead in 2022. Thank you to those who have chosen to make a year-end donation of any size, and everything helps. Thanks again.
I'll jump in.
Thank you, Don. Just one thing, Jim, I'll just
Okay,
point out
go
that
ahead.
this is what the page looks like if you, we've got a donate button on the website, and it'll get you right to this page if you want to donate electronically. If you've ever donated before, it'll pop your information in as well, which is why my name and address are on that screen. So thanks again. And Jim, I'm sorry, go ahead.
Okay, just a brief report then on how we kept some money in the treasury, which we have, as Don reported. We set a goal actually of raising $50,000 for this year, and I'm happy to report that as of today, we are just under 48,000. So it's worked out rather well. Now, you might say, well, that sounds like kind of an arbitrary number, but we felt that that's what we needed. We had some money in the bank going into this year, and we felt if we were going to cover the expenses that Don laid out, that's about what we needed. Happily, we've still got a good chunk of money in the treasury. Don didn't mention that, but I think it's somewhere in the 35,000 or so category. Now, how did we do this? And this is really, I think, part of the good news too, is we've really used a variety of fundraising tactics. Again, another shout out to Carol Engelhardt. I hope she's not getting a big head out there. And Cheryl Quick. We had 3 special events, and I know many of you participated, but just a reminder, the exercise-a-thon in the spring, and then the event with Wendell Potter, the virtual event with Potter in the early summer. And finally, the event at Crooners with Papa John Kolstad in the early fall. So 3 great events. I might mention that the money that's come in has been in 3 very equally divided pots, interestingly. So that's the one category, special events. Secondly, you are led by a very generous board. It's really quite impressive. I've served on a number of boards, and this one is very generous. So about another third of the money has come in from board donations. And then finally, from all of you, and about another third from individual donations. I know many of you on this session have contributed, and thanks for that. We're going to do one final little push next week. You'll be hearing from Judy. And so if you've got a few extra shekels laying around here that you want to get rid of before the end of the year, we'd be happy to put them to good use. And then finally, just one other category would be 2 of our partners, namely the Minnesota Nurses Association and SEIU made donations also. So that's kind of how we've done it. Like I say, I think the good news is we really have a broad-based strategy that will set us up for moving into the future. So thank you.
Thank you, Jim. Appreciate all your work. Fundraising is challenging. Thanks again. So now I am pleased to introduce our speaker for this morning, Rose Roach, who is the Executive Director of the Minnesota Nurses Association and a member of the Board of Healthcare for All Minnesota and a true single payer Medicare for All Minnesota Health Plan champion.
Thanks, Ann. Good morning to all my fellow healthcare justice warriors out there, and greetings from your nurses. So I know that, you've been hearing a lot from us recently at HCAM about this privatization of our traditional Medicare program. So we wanted to just take a few minutes this morning to give you a little bit more context on what's going on and why it is so incredibly dangerous and why we really have to work hard to stop it. So I think Judy is going to put up a couple of slides, and then we're going to watch a video, and then I'll have a brief few comments in regards to some action items for folks. Judy, are you able to pull that up? Great. Can you go to slideshow? Thanks. You can go to the next slide. So just to give you a little bit on the definitions so that you know what we're talking about, because so much in healthcare is based on acronyms, right? So there are two things that are happening inside of our Medicare program. And this is traditional Medicare. We've got Medicare Advantage, which is a whole other conversation of privatization, right? That's already up and running. That is not a good thing either. But this is an attack on the traditional part of Medicare that still exists. For any of you who are on Medicare and you purchase a gap or supplemental plan to cover the 20% that Medicare doesn't cover, that's traditional Medicare. And that's what everybody should go on. Don't buy Medicare Advantage plans. Please, please, please advise your loved ones and your friends who may be getting to Medicare age, go on to traditional Medicare and buy the gap plans. You'll be much better off because the Medicare Advantage plans are nothing but a massive ripoff, and they do cherry pick who they want in those plans. And once you pick one and you get sick, then you will find out whether or not you even have the coverage to take care of you in that Medicare Advantage plan. Many times you don't. So then you'll go, wow, I'll just go back to traditional Medicare then, because they will cover whatever my illness is. Well, not so fast, because the gap insurance plan may call that a pre-existing condition, and they therefore may not cover that condition. So please don't go into Medicare Advantage plans. Please, please go into traditional Medicare and then help us fight to keep traditional Medicare a non-privatized system. So what's happening is these direct contracting entities, they're called DCEs. And also there is one that it appears to be kind of on hold at the moment, but it's equally as threatening. It's called the Global Professional Direct Contracting Program. So you can go to the next slide, please. So I think that the easiest way to explain these is actually done by Dr. Anna Malino, excuse me. She is a past president of the National Physicians for a National Health Program. Recently, they had their convention, their annual convention, or conference, I should say, which is absolutely unbelievably awesome. I learned so much every year when I attend them. And Dr. Malino did a great video to really simply lay out for all of us in layman's terms exactly what's going on inside of traditional Medicare. So Judy, if you wouldn't mind running the video, please.
Sorry, just bear with me for 1 second. For some reason, it's not wanting to go to the next slide, which is where our video is. There we go. Again, I'm sorry for the technical difficulties. Just 1 second.
Judy, maybe we should just have you go to a, to a browser and put the link in. Just exit entirely.
Or would you like me to share my screen, Judy, and show my video?
I am past president of Physicians for a National Health Program and a general pediatrician in San Francisco. We will be spending the next 15 minutes or so talking about direct contracting entities, the latest attempt to hand Medicare to Wall Street. Now, the takeaway for today.
Judy, I can hear it, but I don't see any slides going.
I first heard at a PNHP conference.
The video isn't running. I'm going to try something here. Oh, shoot. I bet I goofed this up. I'm sorry, everyone. It's always so difficult when you're trying to deal with, the technology stuff. That's not right either. I'm going to try it just directly from the website and see if we can get it to go. Let me just make sure I've got all the buttons pushed. I think I do. All right, let's try this.
My name is Anna Malino.
Is that working?
I am past president of Physicians for a National Health Program and a general pediatrician.
Yes, Rose.
We will be spending the next 15 minutes or so talking about direct contracting entities, the latest attempt to hand Medicare to Wall Street. Now, the takeaway for today's talk is summed up by a quote I first heard at a PNHP conference many years ago. When Willie Sutton, a famous bank robber in the first half of the 20th century, was asked why he robbed banks, he supposedly responded, because that's where the money is. Now keep that money in mind as we go through the next 15 slides. By the end of the session, you will be able to describe a brief history of Medicare, Medicare Advantage, and the Medicare money machine, understand the Innovation Center and the global and professional direct contracting model, and finally discuss a winnable strategy to stop direct contracting entities. Now, Medicare has become a tale of many acronyms that some that you've heard of and some you wouldn't expect to see in medicine. Of course, there is TM, which stands for Traditional Medicare, CMMI, the Center for Medicare and Medicaid Innovation, also known as the Innovation Center, GPDC, Global and Professional Direct Contracting Model, DCEs, those are the direct contracting entities, PCPs that I thought were primary care physicians, but no, they're investor-owned primary care practices, MSOs that aggregate those practices. MA stands for Medicare Advantage Insurers. SPACs are special purpose acquisition companies. PE are private equity firms. VC are venture capital firms. And IPOs are initial public offerings. Now, the United States is the only high-income country that does not provide healthcare to all its residents as a human right. In 1965, Congress passed, and as we know, President Johnson signed Medicare into law to cover the healthcare costs of seniors 65 and older. As we know, there is Part A that covers 100% of hospital charges and Part B that covers 80% of outpatient charges, requiring seniors to go into the private insurance market to purchase Medigap or supplemental insurance to cover the 20% of uncovered services. Now, in the 80s, commercial insurance was introduced as Medicare Plus Choice to give seniors a choice of health insurance plans and to achieve the so-called efficiencies of managed care in the private sector. In 2003, Congress passed and President Bush signed the Medicare Prescription Drug Improvement and Modernization Act, implemented in 2006, which added prescription drug benefits to Medicare and renamed and redesigned Medicare Plus Choice into Medicare Advantage. And in 2010, Congress passed and President Obama signed, as we know, the Accountable Care Act that, among other things, established the Center for Medicare and Medicaid Innovation, also known as CMMI, gave them a $10 billion budget every 10 years to test innovative payment and service delivery models to reduce program expenditures while preserving or enhancing quality of care. Importantly, it authorized them to issue regulations free, and I repeat, free of congressional action, and scale up any model that fulfilled their criteria to the entire, and I repeat, entire Medicare program. And that's where we find ourselves today. Now, many health economists hold to the idea that excessive healthcare costs in the United States are due to two things: physician greed and patients getting too much care. In other words, the fee-for-service model that pays for volume. Their solution is to squeeze physicians and then to squeeze patients. Now, to squeeze physicians, they recommend shifting insurance risk to doctors and hospitals, holding doctors accountable for the cost of care, giving them capitated payments for certain population of patients by creating such things as HMOs and ACOs and PCPs and MCOs and IDSs and now DCEs or direct contracting entities. Then you squeeze the patients and make them stop getting so much health care. You increase deductibles, copays, coinsurance. You underinsure them, make them choose between a whole pill and a half, 3 meals a day, or 2. This is how the US uses market forces to control prices. Now, as you can tell from this graph, which compares the increase in Medicare beneficiaries shown by the green bars and Medicare spending shown by the red bars from 1970 to 2020, market forces have not worked all that well to control Medicare costs, although you can argue that since the ACA, healthcare costs have risen at a slower pace, and the cost of Medicare compared to commercial health insurance have always risen at a slower pace. But still, the Medicare budget in 2020 was $926 billion. Now, privatized Medicare, otherwise known as Medicare Advantage, shown in the red bars, has grown as well, from 7 million beneficiaries in 2000, not growing very much until the implementation of the Modernization Act in 2006, then more than doubling after the passage of the ACA in 2010. What is the Medicare Advantage? Why so popular? Well, the Medicare Advantage business model is quite simple, although it does require hiring a bevy of very smart actuaries. First, you make sure that you insure the right population, otherwise known as cherry picking. 2, you make sure you don't insure the wrong population, otherwise known as lemon dropping. 3, you offer inexpensive premiums and health benefits. You upcode and make a profit, and then you give back some to improve the product, such as lower premiums, out-of-pocket caps, cheap eyeglasses. You market to the right population and repeat. Now, at the risk of telling you something that you already know, let's quickly go over just how this risk score gaming works, a scheme that would make Willie Sutton blush, and which is how Medicare Advantage has been drawing serious overpayments since its full implementation in 2006. Medicare Advantage does this by submitting diagnosis codes that create more of what is known as the CMS hierarchical condition categories for each patient. So let's see how this works. Let's look at a 76-year-old female with obesity, type 2 diabetes, major depression, congestive heart failure, with a risk score of 1.03. Now, CMS would pay a Medicare Advantage plan that does not upcode $9,000 for that patient. If, however, the Medicare Advantage plan upcodes, meaning same patient, same medical conditions, but more codes, and gets her risk score to 3.63, CMS will pay that Medicare Advantage plan $32,000. The plan reaps obscene profits, some of which goes to marketing, some of which goes to improved benefits, driving up the number of new members, but most of which is going back into profits, all the while draining the Medicare Trust Fund, driving up Part B premiums, and diverting money from other social services and goods. Now, for each 0.1 increase in risk score at current enrollment levels, there are $15 billion in overpayments, $13 billion from CMS, $2 billion from Part B beneficiaries, and the Medicare Advantage plan takes $3.5 billion in profits. That's for every 0.1 increase in risk score. Risk score gaming creates a major transfer of wealth from taxpayers and traditional Medicare recipients to Medicare Advantage plans. And this is a Medicare Advantage. But wait, there's another piece of the pie waiting to be raided. Medicare Advantage plans account for only 42% of Medicare beneficiaries, and traditional Medicare accounts for 58%. Now, taking home a portion of the $389 billion is fine. But what if these corporations could take home a portion of the entire $900 billion pie? Now, that's where the money is. I'm going to be borrowing heavily from a recent Health Affairs blog published 3 weeks ago by Rick Gilfillan and Donald Berwick, where they described the Medicare gold rush created by Wall Street speculators as they increased the valuation of a Medicare Advantage beneficiary's covered life from an average of about $7,000 to $87,000. Now, to put this into context, Medicare typically pays $12,000 per year per individual. What happened? Did seniors suddenly get really sick? No, the system just got really sick. 4 main business realities drive the interest in these Medicare-related acquisitions. One, expected doubling of Medicare spending from $800 billion to $1.6 trillion in 2028. The consistent overpayment by CMS to Medicare Advantage plans, despite any lack of clinical benefit. The distorted market dynamics that result from these CMS overpayments. And finally, the direct contracting model hoping to privatize part of that $1.6 trillion spend. Which brings us back to the CMMI, the Center for Medicare and Medicaid Innovation, which, if you remember, was tasked with developing models to lower costs without worsening outcomes, without congressional oversight, and then scale models to the entire Medicare population. Now, in 2017, the Trump administration decided it wanted to de-risk all of CMS and pass the entire fee-for-service beneficiaries to Medicare Advantage-like full risk capitated arrangement. In 2019, it unveiled the GEO model, which involuntarily aligned all traditional Medicare beneficiaries to a DCE in 10 large cities without the ability to opt out. Now, in 2021, the Biden administration did halt the GEO model, but it greenlighted the global and professional direct contracting model, which allowed CMS to contract with 53 direct contracting entities in 38 states and DC. Now, the DCEs are a Medicare Advantage-like intermediaries with defined provider networks, although beneficiaries do maintain access to all Medicare providers. There are some very complex constraints on risk scoring, which might or might not be enforced, and it looks like their medical loss ratio will be about 60%, allowing for plenty of home-taking profit. Beneficiaries are aligned through claims, where they access the most healthcare, or voluntarily through their PCPs, their primary care providers. They will get a letter in the mail from the DCE, which they might or might not read, might or might not understand, and presto, you now have a potential 30 million out of the 38 million beneficiaries out of fee-for-service and into a capitated risk-sharing program. Oh yes, these are beneficiaries which specifically chose traditional Medicare because they did not want to align themselves with a Medicare Advantage plan. Well, too bad. Of the 3 GloPro or global and professional DCEs, most are investor-owned. 25 are provider-based and controlled, a mix of ACOs, some for-profit PCPs, and specialty groups. Now, 28 are investor-owned. 22 are either publicly traded or publicly backed by private equity and venture capital firms. Now, the 6 insurers that are the Medicare Advantage insurers that are in the DCE market operate in 19 states with 57% of the entire national fee-for-service population and can eventually cover up to, or potentially cover up to 20 of the 30 million lives up for grabs. So when we say DCEs hand traditional Medicare to Wall Street, we are not kidding. Remember the 80s, giving seniors a choice of health insurance plans, achieving the efficiencies of managed care in the private sector? Didn't go so well unless you own stock in one of these 5 commercial insurance companies, which in the last 11 years had an average stock price increase of 800% and whose average market capitalization increased almost 500%. Compare this to the entire S&P 500, where stock increased 280% and market capitalization increased 245%. All of this tells us what Wall Street already knows. Medicare Advantage, and now DCEs, is the place to be. And where is our place? As physicians used by insurance companies to upcode and now deliver patients to them, as willing collaborators of the new DCE Medicare money machine? I don't think so. So the first thing you and everyone should do is go to pnhp.org and sign the petition to stop DCEs. This is a petition that will be sent to Health and Human Services Secretary Becerra demanding a stop to DCEs. We have over 3,000 signatures and are hoping for 1,000 more before we send him the petition. And then you can call or write your member of Congress demanding an end to the DCE program and for them to protect Medicare. You can write a letter to the editor. Physicians, please collect letters that your patients are receiving from the DCEs and send them to me. That's my email. And seniors, if you receive a letter from DCE, send me a copy. We hope to organize a truth campaign around these letters. Educate yourself about this complicated issue. It's made complicated for a reason. We are expected to throw our hands up in the air and walk away in confusion. Don't do that. Instead, watch the DCE webinar and walk away angry and ready to fight. And always, always collaborate with organizations and organize for national single payer Medicare for all, because, as Willie Sutton said, it couldn't be more obvious. Thank you.
Okay, so a lot there. I understand that, but hopefully it gives you a taste of what we have going on here and what we need to do as activists. It's a little hard for us to say we're fighting for Medicare for all if the Medicare system is going to be owned and operated by this inhumane private sector, profit-driven medical industrial complex. It's like they're trying to say, sure, no problem, we'll go to Medicare for all because we now own Medicare, right? So this is critically important for us to stop. Judy, are you able to put up my last couple of slides?
Yep, just give me 1 second.
Sure. And I think we're on slide number 8. Yeah. So you can see from what Dr. Malino said, they're wreaking havoc, these direct contracting entities, with our traditional Medicare system. They create an incentive for the engagement in adverse selection. She talked about cherry picking and lemon dropping. That just means they want to find the healthiest people to go, and seniors to go into these programs. And once you are no longer that healthy, then they lemon drop you. So that's what those lemon dropping and cherry picking means. They're causing further market consolidation. I'm telling you, market consolidation is not a good thing. It has been really destructive to our healthcare system. It is a major reason why we have costs at the way that they are in this country, is because of this consolidation. They don't allow for more than 7 of these DCEs in any given region. So you can see where they're causing further and further consolidation. And for every incentive, they have every incentive, to supervise care and limit the treatment that our care providers are giving us. They're adding layers and layers of bureaucracy. Of course, they're adding costs through marketing and profit to our traditional Medicare system. We can't allow that to happen. Next slide, please.
Sorry, my computer is freezing on me.
Okay, I might be able to go ahead and get mine up and see if I can.
Sorry about that, Rose.
Use my own. That's all right. It happens. So let me go ahead and share again. I promise you I only have a couple more slides and we will be done with this section. So there we go. I think that's working now. So why is this happening? You heard Dr. Malino again address this, but oh my God, it's all about fee for service. Fee for service, fee for service is what's causing all of this, all of this pain and this heartache and all of these high costs, because fee for service means we're overusing healthcare. None of that is true. This country does not overuse healthcare, we underuse healthcare. And fee for service is no more a culprit of overuse than capitation or any other type of payment system. We have to start to challenge that nonsense when we hear it, because there are absolutely no facts to back up that claim. It is the claim that started us on this managed care theology craziness back in the 1970s and 80s, and it goes on today, where we will continue to hear, even from many of our friends who believe that healthcare has to be changed in this country, they will talk about, well, if we could just get rid of fee for service, that's what's driving overuse, because those greedy doctors are just prescribing all kinds of tests and services and et cetera in order to make money. And that's how we're overusing healthcare. Not true. Absolutely false. Okay, so we have to be challenging that. And there was a study that was done at one point about looking at this issue of overuse. It was called Overuse of Healthcare Services in the United States, an understudied problem in 2012. But interestingly, the editor of that particular what do I want to say, publication, sorry, called ARC Intern Med. His name is Michael Katz. He wrote a follow-up to the publication of that study, and it was called Overuse of Healthcare. Where are the data? He was so struck by how little evidence that the writer, the author, Korenstein et al. Found that he felt compelled to comment on it. And he said, what is most striking about this report is how hard the authors searched for data on overuse of healthcare and how little they found. They viewed 21 years, and they actually, that's a typo, it was 31 years, of the medical literature and evaluated 114,831 publications, yet they found only 172 articles that addressed overuse of healthcare. So the question that Katz asked, where's the data, is a good one and an important one. After a half a century of screwing around with HMOs and PPOs and ACOs, and as I say, EIEIOs, all of which were promoted in the name of reducing overuse, which was caused by fee-for-service, you'd think we'd have some evidence of an epidemic, of overuse. Well, guess what? We still don't. And for the small pockets of overuse that do exist, we have no evidence that they are caused by fee-for-service. So just a reminder for all of us, right? Let's reground ourselves in what we know a healthcare system should be about. It should be universal, including everyone, no exceptions. It needs to be comprehensive and cover everything related to health. No carve-outs for mental health, no carve-outs for dental, for hearing. All of those things are part of our health. It needs to obviously be affordable. And that means it has to be collective for society. It has to be based on a progressive tax system. It has to be something that we can actually all afford and not have to actually worry about bankruptcy when we get cancer. No other country in the world has such a thing going on in their healthcare system. It must be equitable. We must make sure that we deal with all of the racial and socioeconomic disparities that exist, and gender disparities that exist within our current system. We have to get rid of them. We can't even begin to address them until we get to a place where we have a financing system that actually is equitable and makes sense and gets everybody access to care. It must be centered on patients. For crying out loud, it's a healthcare system. That's what it should be. In the center of everything should be patients and patient care, not whether or not a private equity firm is going to make money on someone being sick. And then it has to be publicly funded. We have to use the tools available to us on modern monetary theory and progressive taxes that can only be available through a people's government to be able to guarantee affordable health care for all. And we must publicly administer it. It has to be accountable to all of us in order to provide the efficiencies, particularly in administration, that we know we can achieve through a publicly financed and privately delivered healthcare system. Deprivatizing healthcare financing will eliminate the high costs, the inefficiencies, and the inequities of the private corporate greed that exists within our current system. So here's what we need to do. I'm going to put up the names of who you need to call. We are particularly targeting the Democrats at this time simply because they have the majorities in each of the Senate and as well as in the House. And because, as you heard Dr. Malinow say, Congress doesn't have any oversight rights on this. We need them to step up, go to CMS and tell CMS to knock it off. Stop these programs. Congress needs to look at them and really take a deep dive and figure out, are they really doing what they say they're supposed to be doing? Because they actually aren't. So we'll give you the wrap. This is the basics. I'm calling to ask, I'm sorry, I forgot the K in there, to ask that, Senator Klobuchar urge CMS to halt the models such as the global and professional direct contracting and direct contracting entities that involve insurers and investors in our traditional Medicare program. Tell CMS they must make sure that CMS does not test models in traditional Medicare that include intermediaries and complicated complicate healthcare financing, which in turn increase costs that are not going to actual care. Even call Secretary Becerra himself. I am urging him to please stop the implementation of all direct contracting entities. There is nothing more that there is nothing more than backdoor private. They are nothing more than backdoor privatization of our traditional Medicare program, and it must not be allowed to happen. That petition that Dr. Malino mentioned at the end of her presentation there were over 13,000 signatures on that petition. It was delivered last week, or an attempt to deliver it last week was made to the HHS, and they were refused entrance to deliver the petition. I am pleased to announce that we just found out literally this morning that the PNHP leaders have got a meeting scheduled for next week with HHS to present that petition personally and to share all of this information and the concerns that they have about this privatization scheme of our traditional Medicare. So please make the calls. Klobuchar, Smith, Craig, McCollum, Omar, Phillips, and then Secretary Becerra. And those are the numbers. We'll put those over in the chat so everybody has access to them. And I'll fix up the typos on the script for what we want you to say to them. And it's okay to just use the smaller one that I typed up for Secretary Becerra and use that with the Congress people as well as our senators too, if you don't want to get into all of that other specifics. So this is important stuff. We got to stop the privatization of our traditional Medicare. So please help us, activists. And I'm done, and I don't know if we have time for questions. I'm happy to take them if you want. I know there's some in the chats and in the Q&A, or if there's not time, I can look at those and respond to folks afterwards.
Hi, we have about 10 minutes for questions, I believe. Okay. And first question, thanks, Mark, for handling a couple of those. Don is asking if Minnesota is one of these states. And that would be hard to know, but Rose, I happen to have a letter from CMS announcing this all the way back to April. I will tell everyone that this caught all of us in the health policy advocacy world kind of by surprise, and we are working hard to catch up. I see Minnesota on the list of potential entrance into this great opportunity for investors and insurers.
Right. So we are, so in 2020, actually starting in 2020, some of these already went into play. They did not go into play here in Minnesota, but I believe we are on the list to potentially have them entering in 2022. So, you know, it's, yeah, we're not outside of this scheme, that's for sure.
Mary Lund is asking, how will we know that you're getting a letter about a direct contracting entity? And
I don't know that you're going to know you're getting a letter. You'll just get a letter. And, you know, this is one of the things you heard, again, Dr. Malino say, you know, you get a letter for if you're on Medicare, and I'm not yet, I'm close. I'm a little over a year away. But I know that people get inundated, right, when it's time for open enrollment and all of that kind of stuff for Medicare. So you will be getting the, and a lot of people are like, I don't even know what this is. What do I do with this? I don't understand this. And why should they, right? This isn't stuff that we should have to be dealing with when it comes to our healthcare. I'm telling you, take a look at them, because when, you know, it should say something in there about whether or not you're being placed into a DCE. And you heard that also from Dr. Malino said, in some cases, you're not allowed to even opt out of them. So you can't even get out of it. This is really serious.
And just a comment to add to that, Rose, I see by the names of the DCEs on this letter from CMS, it's going to be hard to recognize. They're going to sound like a healthcare provider, but it's really a business behind that. So, but most of them are investor owned. So I think it's going to be a challenge. You got to get it stopped. There was a comment from Claire saying that this is complex, but a great issue to organize around and keep us informed, and we will. And Mark Friedman is asking, the DCEs claim to allow patients to go to any Medicare provider. Can they limit this? Yes. And how does that work? Yeah.
Yeah, I mean, anything that's connected to the private sector, part of the way that they try to say that they're keeping down costs is to limit the networks, right? Limit where you can go. You will be placed into an HMO type of vehicle, a managed care type of vehicle. So you will not be able to go just anywhere like you can under traditional Medicare, or should be able to. You'll be treated the same as those who are in Medicare Advantage plans. It is my understanding that they absolutely can limit the providers, and that they do limit them. So I don't think that it is true that the DCEs, if they're claiming that you can choose any medical provider that you want or any Medicare provider, that's almost, it's almost trick language to me, because when they say Medicare providers, pretty much any providers will take Medicare. There's more doctors here than that could comment on that than I can, but that's my understanding. Whereas within the Medicare Advantage program, not so much. So what do they mean when they say any Medicare provider? If they mean any Medicare Advantage provider, now we're talking a different system, because that's where your limited networks are. I know I see John Crossan is asking, where is the accountability for DCEs? Well, John, you know as well as I do, there's limited, if any, accountability for any of these private entities. I mean, look at our own systems here in Minnesota. We have got HMOs in the private sector involved in our Minnesota Care programs. We've got them involved in the medical assistance, which is Medicaid here in Minnesota. And guess what? When we turn to them and say, sort of like, show us where we give you X amount of precious taxpayer healthcare dollars to go to healthcare, where are you spending it? How much of that money are you putting into the actual care of the individual? And that means paying the providers, versus how much of it are you keeping it for yourselves? They're nonprofit insurance companies in Minnesota, and that's a misnomer. We all know there's no such thing as a nonprofit in healthcare. They're just sitting on reserves. They're keeping the money. They just don't have to dole it out to shareholders. So there's barely any accountability. That's the problem. Look at how much money has been charged to United Health Group in penalties for all of that upcoding that you saw, again, that Dr. Malinow addressed. They have paid billions in fines. Doesn't mean anything to them. It's nothing compared to the market that they have and that they profit off of. So this is why this is a scam and really scary stuff, and not okay, and something we've got to keep our eye on. And we will get a copy of the statement out to everybody. We will figure that out. Can this be emailed to us so we can call? Yes, hi, Becky. We will absolutely make sure you get the right wording. I was typing a little too fast, sorry about that, so you can really put the pressure on. Labor had a meeting with Representative McCollum just a week ago, and I brought this issue up, and I turned to her staff and said, hey, pay attention to what I'm saying here, because this is like really important. And she just kind of nodded and said, okay. I just don't think that overall Congress is engaged in this. It's not on their radar screen, and we got to get it on their radar screen. I will tell you that Representative Katie Porter, she's a congresswoman actually out of the Orange County area in California. She thankfully has taken up the banner on this, and she is really making it a cause. So I'm hoping to maybe chat with Congresswoman Omar about this as well, because as a leader in the Medicare for All caucus, I think that, Ilhan could be really, really helpful for us as well. Mark Friedman, this seems to be a way to pre-exempt objections. Sure. Yeah, I mean, there's all kinds of shenanigans they're playing to make sure that we don't get an opportunity to say, wait a minute, there's a problem with, we object to how things are going. Ann, did you want to say something? Oh, okay. So Adina says, who has a final say on affordability of MNsure rates? Is it the Health Finance and Policy Committee? Liebling and Hoyt, since it is open enrollment, is a particularly good time to let your reps know that these rates are not affordable for Minnesota individuals. Yeah, well, I mean, there's a MNsure board. I'm pretty sure the MNsure board, they look at, MNsure is just all it is an insurance marketplace. And so they're at the whim of the market, just,
I think it goes through the Commerce Department, Rose.
Yes, it is common, but I'm saying
Yeah.
MNsure has a MNsure board, and the
Right.
MNsure board, you're right, then works with the Department of Commerce to set these rates. And, it's all based on this crazy, well, how many people actually utilized the product and had, got sick and had to actually cost us money. Well, that means we got to raise our rates now again. And, they try to justify all of that. But there isn't any real justification for it because risk adjustment isn't a real thing when it comes to health. And so that's the process that's used for that. And you're right, MNsure is not affordable. And there are a lot of things that we try to do to make it affordable, but it's all working inside of this private market. We can't do healthcare like this. You can see no matter how many attempts that we keep trying to make, they're not working. Why do we keep trying the same stuff over and over again when we know what the fix is? That's why we're all here today. Judy said, I discovered that my dentist of many years decided not to take Medicare patients, so I couldn't get coverage for them out of network. Yeah, so you all know that there was an attempt in the Senate, God bless Bernie Sanders, he's still trying to get dental included in Medicare because it's not, right? You have to buy that generally as a separate type of a gap insurance plan. Some of the Advantage plans will cover Medicare, dental, but all of that comes at a cost somewhere, so don't fool yourself about that. Here's the thing, interestingly enough, as the most of the Democrats in the House and the Senate were fighting to have dental, hearing, and vision all part of the Medicare system, the dentists fought it. They didn't, because in their mind, Medicare rates are too low, so they didn't want to have dental covered. So we're down to hearing aids, and anything to do with hearing is going to hopefully at the very least be covered. At least that's what passed out of the House. As I said, Bernie is still trying to get dental included, but this is what we're up against: is these kinds of major lobbying entities that are able to sort of get in front of Congress and get this stuff in a place where it's not so good for patients necessarily. Let's see, it is so complicated for people. I know, Becky, I get it. And that's what's frustrating, is it doesn't need to be. It doesn't need to be this complicated. It's very purposely being complicated for us, right? And complication and fragmentation absolutely adds cost. Greg is asking, has American Medical Association taken a position on DCs? I don't know. I don't know if any of the docs that are on would know whether or not AMA has taken a position on DCEs. I don't know, sorry. Adina, Blue Cross Blue Shield outsourced our state Medicaid claims processing to the for-profit Amerigroup. Well, there you go. How was that even allowed by our state legislature? Well, it's a really good question. And let me do some digging on that. I'm just guessing that as much as it says you have to be a nonprofit, right, to sell insurance in Minnesota, and that hospitals have to be nonprofits, and don't kid yourself, they're as much a culprit in this crazy scheme as anybody is, although at least they provide care, right? But there are loopholes. And I'm guessing there's a loophole that the Blue Cross Blue Shield is nonprofit in Minnesota, but they can offshoot to subsidiaries that are for-profit. So I'll check into that for you, but I'm guessing that's most likely what the answer is on this. Hillary, did you say? Oh, I'm sorry.
I will suggest that we take just one or two more questions so that we can get on to Rose's next.
I'm so sorry. I lost track of time.
I know, because it's so much fun, right?
I have a tendency to do that. I'm so sorry. Did you say that the insurance companies hold the reserves from public programs and don't have to account for the money? Yeah, they don't have shareholders. So if you're a nonprofit insurance company, you sit on reserves, and the reserves are supposedly to be used to buy down premium costs. They're supposed to be put back into potentially, like in hospitals, there should be charity care and things of that nature. It just doesn't pan out. for insurance companies, they pay pretty exorbitant salaries and benefits to the CEOs of those companies. They certainly don't use them to buy down premium costs or any of that kind of thing. They invest. Many of them, we found hospitals investing in the Cayman Islands, putting offshore investment accounts together. And that just feels criminal almost, certainly to nurses who are fighting to provide care and can't even, get these hospitals to provide the amount of staff they need to take care of, what we're seeing with COVID patients and everything else in the hospitals. It's pretty insidious. So no, they don't have shareholders. They are not accountable to Wall Street, so they don't have to distribute, like a profit would distribute shares. That's not what happens when you're a nonprofit. They just sit on it and pay each other for the most part. So the last question is just, isn't there a relationship between dental health? Of course there is. Yes, Bethany. A lot of people, there was a RAND study done, and I want to say it's probably a couple of decades old now. I would bet the outcome isn't different. People were asked who were uninsured, if there was one thing you could do tomorrow, if you suddenly could access all of, healthcare, what would you do? And something like 75% of them said, I go to the dentist, because dental health affects all the rest of our body, right? If you get an infection, it goes into the blood, et cetera, et cetera. So yes, it certainly seems like dental care is an obvious one that should be covered, but it is not. We have to buy separate insurance because somehow we've decided our eyes, ears, and teeth are disconnected from our health. Insane. So I'm going to quit because I know my time is up. Thank you, everyone. Thanks for engaging in this conversation. Please call.
Next up, Rose is going to talk about a really exciting and positive development at the state legislature in which she had a big part. So I want to point that out as well.
So this will be really quick and easy, everybody. It's just a quick report out. So on the national level, you all know that there is a Medicare for All caucus in our Congress, and it is, I think it's basically House-based, and our very own Congresswoman Ilhan Omar is one of the co-chairs of that caucus. And so we were thinking, why not do that on a state level? Why not go ahead and have a Minnesota Health Plan caucus? That's the name of our state bill, right? Senator Marty is the designer of that bill for many, many years. He's the author in the Senate. And then Representative Cedric Frazier, a champion of this, is also the author in the Minnesota House. So guess what? We now have this. We have a Minnesota Health Plan caucus. It consists of legislators who are committed to educating, organizing, and also implementing the Minnesota Health Plan. They're dedicated to running on it and making sure people know that this is the way we're going to fix our healthcare problems. The leadership currently is Senator Jen McEwen from the Duluth area, Senator Omar Fatah, who is, I believe, from the Minneapolis part of the metro area. Representative Liz Bolden, who is a registered nurse from the Rochester area, and Representative Liz Ryer, who is out of Eagan. So those are the current leadership. They are having monthly meetings. They said that there are tons and tons of enthusiasm amongst legislators about forming this caucus. They're planning to do an official launch of the caucus around the beginning of the legislative session in 2022, so sometime January, February, and they're going to have a press conference. They want to follow that up with in-district town hall meetings. So we're all going to be called on to attend, to get people to attend, to make sure that we turn folks out to attend those in-district meetings to have a conversation about the Minnesota Health Plan. They're working very closely with Healthcare for All Minnesota, with our Healthcare Justice Allies Coalition. And I just want to note, that this is really a significant development for us in the movement. We absolutely must build political power inside the Capitol as we here as activists build our grassroots people power on the outside of the Capitol. So working hand in hand, this is a real movement, and we are really excited that this is the first steps to creating a true statewide campaign that will get us the Minnesota Health Plan here in Minnesota. So we will look at inviting some of the caucus leadership to come and talk at a future quarterly meeting to give you all an update and connect you with them and them with you. So it's very exciting.
Thanks a lot. Appreciate that, Rose. And indeed, it is very exciting. Our next, I'm going to share my screen now again. And our next presenter is Carolyn Henke, who is a volunteer with us and is handling a lot of our social media communications. Current slide. There you go. Let me make that work. Carolyn, I want to introduce Carolyn to all of you too. She's been a super volunteer for us. Helped out last summer when we tabled at the Pride Festival, which was one of our, few big in-person events. But in the absence of a lot of in-person events right now and ongoing, we need to be using social media to our advantage to help get our message out. So
yes, thank you.
Welcome to this movement. Thanks, Carolyn.
Yeah, thank you. Thanks for having me on. And I really appreciate the previous speakers that went. That was informative. I was telling my mom to tell her clients not to use Medicare Advantage. So I do the social media for Healthcare for All Minnesota, which includes Facebook, Twitter, Instagram, LinkedIn, and YouTube. There hasn't been a lot of activity on YouTube. I just want to say that, but we are doing, hopefully in the near future, we can do some more things on YouTube, as that is a great platform. The social media sites that are our biggest and that we primarily use are Facebook and Instagram. That's where we have the most followers and the most interactions with those followers. But Twitter and LinkedIn are we still use those. We just have the most interaction mainly on Facebook. And we like to use social media for all things that can't be done in person. It can really reach a wider audience. It especially reaches a younger audience who, probably isn't super aware of what's going on with Medicare, but still wants to be involved in changing healthcare, because the Gen Z population, which I'm kind of a part of, and I'm also kind of a millennial, I'm like a zillennial. We are very interested in changing the way that our country is structured. And so reaching that generation is super important for Healthcare for All. And making content that's relatable to them is very important. So even spreading the message about Medicare for All, or about the Medicare Advantage and how it's harmful is still important. So the way that we can spread our messages on these social media platforms is to interact with each post that is posted on Facebook, Instagram, LinkedIn, and Twitter. And you can do that by sharing the post to your personal page. I think Jessica over the summer did a tutorial about how to share and use social media for the members of Healthcare for All. And if that's requested again, I could potentially do that depending on the timing and hours. I want to also say I'm a grad student at the University of Minnesota. I'm studying public health with the degree in community health promotion. So my time is split a little bit between here, school, and I also work at the Minnesota Department of Health. I just wanted to mention that. And other things that we can do for to spread our message are, again, sharing what's on the social media pages that are listed. So Facebook, Twitter, Instagram, and LinkedIn, making sure that you're following them. You can turn on notifications so you'll be notified when a post is uploaded to those sites. And then also, if you ever see anything that is related to Healthcare for All, like articles or things like that, you can email me. I forgot to put my email on here, but it is carolyn.handke, so my name that's right here, @gmail.com, or email it to one of the board members and they can get that information to me. And if we find that it's relevant, we can make a post on it. So that is pretty much all I have for our social media. So I'm just encouraging everyone to keep spreading information, because for social media, usually on other other organizations, if they're non-political, you can advertise and get more interaction that way. However, Healthcare for All is considered a political organization through the eyes of Facebook and Twitter and LinkedIn. And so we are not able to do any paid promotions. So that is why it's really important to really share our posts, because that's the only way we can keep getting our message circulated through the internet, is by other people sharing it, since we aren't able to do any paid promotions due to the limitations from being a political organization. I don't know how other organizations do it, but we've been running into issues with not being able to do any paid promotions. So that is all I have, I think, for our social media. Feel free to ask any questions, and I look forward to keep working on this. Thank you.
Thank you, Carolyn. We so appreciate your work and your expertise on this. I am just going to kind of end our meeting today with some announcements about educational opportunities coming up and about base building our base of support. I will first just refer you to the 3 sessions that provide some social media training that were done last summer to improve our use of social media sites. And these were headed up by Jen Crawford, who is the Executive Director of Physicians for a National Health Program, Minnesota, one of the interns for PNHP Minnesota last summer, and Carolyn, and then Jessica Koffenberg, who was with us until late last summer. They are excellent. They are on our YouTube channel. So if I can get you to go to our Healthcare for All Minnesota YouTube channel and review those videos. I had to learn myself that when you go to Healthcare for All Minnesota on YouTube, you have to go under videos, and then all of our videos populate, which include our meetings, our educational offerings that we've done back at least 2 years. And so you can always go back and check those. And again, interact with these social media sites. I mean, I personally have to remind myself to go in there and look and interact with them as well. But we need a lot more interaction so that they can kind of circulate more often and start popping up for people. So I put the addresses on there. Please sign up, set up an account on at least 1 or 2 if you're not on social media at all. And again, continue to write, call, and respond to action alerts. Rose created an action alert for us today on this very important subject and a huge threat to traditional Medicare, our single payer system for seniors and the disabled in this country. We have to take action on this. So you will get all this information in the slides in our post meeting email that will come out in a couple of days. Also see the calendar at our website address for other meetings and events. Judy has gotten our calendar up to date, and anything that is open to the public, you will also be able to register for using a link that is on the calendar, which might make it a little easier. If you can't find it in your inbox, you can check the website calendar and it should be there, and you should be able to register, which is yay. That's a good improvement. So this Thursday, December 9th, we do have an educational event coming up because, we couldn't take a month off. So we've got, I think, an interesting program coming up. We've got kind of a wrap up and looking ahead. We're going to have Kip Sullivan back to do a quick review of the series that he just did and answer some questions. We will actually, I plan to show this video again, and in case there are people who didn't make it to this meeting but do make it to an educational event and you want to see it again, and maybe we can field some questions then as well. And then we're going to do a look ahead to this campaign for a bill in Minnesota that we've been working hard on, and Ken Engelhardt on our board has been heading up, and with Rose, the building relationships with the other organizations that we're going to need to work together to make some progress on this issue. And then Thursday, January 13th, our kind of second Thursday education is going to be sponsored by and held by Physicians for a National Health Program Minnesota. It's going to be their annual meeting and program. They have our health policy staffer from Representative Jayapal's office will be joining us for that event. A panel presentation on the public option, which is actually several proposals and pros and cons, and then their 2022 goals and a fundraising effort as well. So I hope that you are able to join us for that. So, one more thing on events coming up. If anybody is accustomed to listening to the Progressive Democrats of America on Sunday afternoon, and you could go to Google PD America if you are not on their mailing list, I see that Wendell Potter is going to be on the call on Sunday afternoon. It's 3 o'clock, right in the middle of the afternoon, but if you're available and can hop on the computer, you can hear what he has to say. And I just am including references because the more you know, these all come out with all of our slides and websites of organizations who are with us. Always useful to know that we're not alone. My contact information here in case anybody wants to get a hold of me. And I think I will pass this over to Judy for a wrap up and post meeting information. Thank you all for coming today.
Thanks, Anne. Thank you everyone for attending. We really appreciate you taking the time on your Saturday morning to join us. As Anne had mentioned earlier, we will be later this week sending out the slides for you. We'll send the link for the video as well, the DCE video by Dr. Anna Malino, sorry. And so please be on the lookout for that. If you have any questions, always feel free to email us at info@hca-mn.org and we'll be happy to help you. I don't see any questions in the Q&A currently. So with that, I'm going to say thank you, and we hope to speak to all of you and appreciate your efforts in helping us further the cause for healthcare and for all. Bye-bye.